nephropathy. Now, this is essentially synonymous with chronic kidney disease, but it explains more what's going on in the tissues. So, it's chronic kidney disease due to changes in and damage to the nephrons. Now, there are literally hundreds of different causes of nephropathy, but the most common causes of nephropathy in this country and probably around the world are diabetic nephropathy and hypertensive nephropathy. Now, these have different etiologies and different pathways of pathogenesis. However, just understand that the diseases can sort of overlap and interact. So it's these in this day and age, diabetes and hypertension sort of come hand in hand and are both involved in metabolic syndrome. And so these diseases can both sort of coexist and exacerbate each other. Okay, with that being said, in this video I'm going to focus primarily on hypertensive nephropathy, and in the next video I will talk more specifically about diabetic nephropathy. So, hypertensive nephropathy. Well, before we get into it, I want to talk a little bit about the glomerulus itself. Now, remember, the glomerulus is made up of an afferent arteriole that comes into a small tuft of capillaries and then goes out an efferent arteriole. Now, normally in the body, blood pressure in the capillaries is quite low. Normal systemic capillary pressure is, 30 to 35 millimeters of mercury. However, in the glomerulus, these pressures are 60 millimeters of mercury or more. So just keep in mind that even when we have a normal healthy capillary in the glomerulus, these are capillaries that are exposed to very high pressures. But the body has mechanisms to keep these pressures in a very tight window. And this mechanism primarily is the fact that there are arterioles on both sides with smooth muscle cells, right? So we can vasoconstrict or vasodilate the arterioles coming into the glomerulus or in the arteriole coming out of the glomerulus. Now that allows us to have exquisite control over both flow and pressure in the glomerulus. So we can keep this pressure in a very narrow range, irregardless of systemic blood pressure. So we can have wild swings in systemic blood pressure, and we do on a daily basis. If you ever take your blood pressure, if you take your blood pressure first thing in the morning and you haven't gotten up from bed yet, it may be a little bit below what we consider normal, systolic of 120. And we head out to the gym and step up on the treadmill and start working out. Even a healthy person will have a systolic that quickly rises to 180. Now, in our systemic capillaries, there is going to be a corresponding swing in pressure from the normal of 30 up to maybe 50. But in the glomerulus, because we have this exquisite control and we have already high pressures, if we raise them much more, we are going to be putting our capillaries at risk. We can decrease the amount of pressure that is transmitted into the glomerulus, or the pressure change that's transmitted into the glomerulus, by vasoconstricting the afferent arteriole and or vasodilating the efferent arteriole. And that's just one example of how. So one of the protective mechanisms that we have is that we can decrease the transmission of systemic hypertension because of this exquisite control that we have of the blood flow into and out of the glomerulus. So I said that hypertensive nephropathy is one of the most common causes of nephropathy, but it is still relatively rare considering the number of people with hypertension. One of the reasons is because we treat hypertension nowadays, but the development of hypertensive nephropathy is much less common than other diseases that are caused by hypertension, like coronary artery disease and cerebrovascular disease that can cause strokes. Why is it less common? Well, a lot of it has to do with these ameliorating factors that are built into the kidney. But I wanted to talk about, there's sort of three factors to consider for the development of hypertensive nephropathy. First, there is the degree of systemic hypertension. Right, so a person with a systemic blood pressure like President Roosevelt had back in the 1930s before we had good treatment with a systolic blood pressure northwards of 300 versus, a person that has moderate hypertension of 145 obviously is going to have more barotrauma to their glomerulus. The second factor is the transmission of systemic hypertension to the glomerulus. And this really is a variable that relates to our body's ability to maintain a steady pressure in the glomerulus by appropriately dilating and constricting the afferent and efferent arterioles. Now the third variable is the tissue susceptibility to damage. Now, let me move over a little bit to barotrauma, I should say. Now what determines that? Well, there are going to be genetic inherited factors, and there is going to be there are factors related to sort of the pro-inflammatory condition of the body. The more inflammation we have, the more likely we are to have damage to the glomerulus, and you'll understand this when I talk about how important inflammation is to this process of the development of hypertensive nephropathy. And then, of course, other diseases. Chief among them would be diabetes. Also, obviously, more rare, but not as rare as you think. I'm surprised at how often I come across it, is the congenital absence of a kidney. So you only have, if you only have one kidney, the other kidney is going to be more susceptible to pressure changes. And, the list could go on. Okay, so what happens exactly on a tissue level with the development of hypertensive nephropathy? Well, it really all, for hypertensive nephropathy, it really sort of all starts out in the afferent arteriole. And I draw a little bigger picture of this. So we have the afferent arteriole, then again we have the glomerulus, and we have the efferent arteriole. Okay, so what we have here is high pressures in the afferent arteriole, and the afferent arteriole tries to compensate by constricting the smooth muscles. and it probably does okay for a while. It tries to restrict the blood flow into the glomerulus. So by decreasing flow, the afferent arterioles are making an effort to decrease pressure. Now, interestingly enough, on the efferent side, we're having vasodilation. And this usually works quite well. However, just keep one thing that happens with diabetes is when you have diabetes, you actually increase the activity of the renin, angiotensin, aldosterone system, and the angiotensin actually causes the efferent arterioles to constrict. So that is one way that diabetes sort of works synergistically with hypertension to cause nephropathy. Now, when we have this high pressure in the arterioles, in the afferent arterioles, these smooth muscles are constricting, and over time they are constricting so much that they start to hypertrophy. So we end up with these enlarged, hyperactive, smooth muscle cells. So that's sort of the first phase. It's just a compensation. We haven't started decompensating yet. However, as pressure forces continue to rise or continue to be exerted here on the wall of the vessel, we are starting to cause barotrauma, trauma from pressure, both on the endothelial cells and on the smooth muscle cells. Now, the smooth muscle cells respond to this injury from the barotrauma by, first of all, excreting a bunch of cytokines, which causes inflammation, and second of all, independently, they start to extrude a extracellular matrix, fibrin and collagen, and some lipids and such into just below the endothelial cells. So this results in narrowing the lumen of the vessel. Now, when it gets narrow enough that it can actually cause, so actually let me go back. So this type of lesion here is called Highland arteriosclerosis. So we have sclerotic lesions in the afferent arteriole that have a hyaline appearance. Now, hyaline, a lot of people get confused that this suggests that this is similar to hyaline cartilage. It is not. They both share the same root from Latin, which means glassy. So this has a glassy appearance under the microscope, but it's made up, it has a very different composition than cartilage. It's made up of fibrin and collagen and some lipids. So this eventually will cause decreased blood flow to the glomerulus to the point that we start to have glomerular atrophy. So we have ischemia to the glomerulus, and it causes the cells to go into a state of apoptosis or just die from necrosis. And this is due to chronic ischemia. Now, as this ischemia continues, cells inside the glomerulus begin to extrude a hyaline-looking substance inside the glomerulus as well. And we end up with a glomerulus that is filled with hyaline. It's called hyalinization of the glomerulus. So obviously, when the glomerulus is filled with hyaline, the nephron is no longer functioning. Now, remember, even before the glomerulus is completely filled in with hyaline, the blood flow is not only decreased to the glomerulus, but it's also decreased to the efferent arteriole So we have decreased blood flow. So while we are beginning to have glomerular ischemia, we are also having tubular ischemia. So we end up with tubular necrosis, the cells die, and similar to the glomerulus, the tubules are filled in with hyaline. Now obviously what I just talked about here was just with one nephron, but this is happening in thousands of nephrons around the kidneys, and when we get to a tipping point and enough nephrons have become filled with hyaline and are no longer functional, then we develop chronic renal insufficiency. And if this disease is not headed off by controlling the hypertension, then we will eventually develop into end-stage renal disease and possibly need dialysis.